For my clinical pattern, I have lumbar muscle strain, and this is basically an injury to the lower back that can result in spasms and soreness within damaged muscles and tendons. For patient demographics, the usual age group this is seen around is 20 to 50, and other research shows that it's emphasized in 40 to 80. With gender, you can see a higher prevalence within females, and outcome tools that are used for low back pain include the Oswestry Disability Index and the Roland Morris Disability Questionnaire. With the history of the current condition, the onset or mechanism of injury can be caused from a muscle tear from excessive stretching or tension on the muscle. Also, it can be a muscle spasm, and that can lead to increased pain receptor stimulation. As for the aggravating factors, with the more severe tear, all movements can be painful, but especially with flexion-based activities due to stretching of the lumbar extensors, as well as rotation and side bending. And for easing factors, it can be rest and ice. As well as for the 24-hour pattern, in the morning they can see stiffness that lasts longer than 15 minutes since there is inflammation from this. And then with the afternoon and evening, there can be more pain with activity, and then possibly the pain will subside after stopping the activity. With sleep, it can be seen with moving around that can increase pain, and then also sudden movements that can wake a person up. I do think that a systems review or review of systems could be beneficial for this. For the physical examination portion, I didn't notice any precautions or contraindications for it. So for active movement testing, there would be limited and painful extension, as well as bilateral side bending and rotation. For passive movement testing, you would see the same painful inflection, and then side bending as well as rotation. I did not put any resisted testing because if I was suspecting that it is a muscle strain, it wouldn't be good to do the resisted as it could cause pain. And then for accessory motion testing, there could be possible hypermobility of the lumbar spine. And since there's no radiating symptoms, I wouldn't see a need to do any neuromobility testing unless there's something else that states otherwise, like the differential diagnosis. And then for the special test, I would do the prone instability and PAVM, and then those are the sensitivity, specificity, and likelihood ratios for both. And then lastly, for palpation, there could be tenderness over the lumbar paraspinals or the QL, and then there could be possible absence of tenderness over the spinous processes, but also people do tend to have tenderness on the spinous processes even if there isn't an issue. So the research just shows that it is possible, so I just wanted to make sure to put that in there. For the differential diagnosis, the possibilities could be spinal foraminal stenosis, herniated disc, degenerative disc disease, vertebral fracture, facet joint dysfunction, or myofascial injury. For diagnostic imaging, the two most common are X-ray and CT scan, and then the MRI, radionuclide bone scan, and electromyogram are also used to identify this. For signs and symptoms that indicate that there might be a need to refer back to the physician would be cauda equina, and this is pain accompanied also by fever, weakness in the leg, and most importantly, loss of control in the bladder or bowels. There can also be pyelonephritis, which is also with the fever, back pain, but there's a history of multiple urinary tract infections. With osteomyelitis, there's low back pain and fever, and then rhabdomyolysis, which is muscle breakdown, can be symptomized with back pain, fever, high levels of toxins in the bloodstream, and then individuals more at risk for this would be people who are overworking their muscles, and this would be athletes or even manual laborers. So surgical indications or options would be for the following symptoms. The first one being radicular low back pain, and an epidural steroid injection can be beneficial for this. And then for debilitating persistent radiculopathy, secondary to a herniated disc, a standard open discectomy or microdiscectomy can help, but it only has a moderate short-term benefit. With severe spinal stenosis, a decompressive laminectomy can be helpful. And then severe radiculopathy after a herniated disc disease surgery, a spinal cord stimulation could help with that. And then these are my references.